Magandang gabi po sa ating lahat. Welcome once again sa ISIP-ISAK, our conversations on faith and society. Ngayong gabi po ay madaling araw din sa Toronto. We have someone from the University of Toronto. He was faculty and is continuing to be consultant, no? Doon sa isang hospital doon. And it's very nice na he's prepared to wake up very early dyan sa Toronto just so he's with us. We have with us our guest, si Dr. Maselle Virey. Siya po ay isang psychiatrist and it is a joy to reconnect with him after many years. Kasi po, I have known him since he was a student sa UP. And then at College of Medicine siya, together with some of our friends, kagaya ni Dr. Sally Vios. And then he migrated sa North America. And I have not seen him since, except for once nung ako'y nag-bisita sa Toronto. And I'm very glad to reconnect with him, no? Itong technology is a very great gift kasi yung mga experts natin who are now scattered all over the world, no? Actually, gusto ko na itong mga IVCF graduates mag-uwian sana, no? Kasi marami silang experience and learning. Pero ngayon, that is available to us now because of the technology, no? So now we have si Dr. Maselle Virey, who will be with us talking about the mental health issues that have surfaced itong panahon ng pandemic. So welcome, Maselle and Mikey, thank you for being with us sa umagang ito at sa gabing ito. Marie will start the discussion with us.
Maraming salamat, Ate Melba. Muli po, magandang gabi sa lahat at magandang umaga sa ating guest na si Dr. Maselle Virey at sa kanyang mabuting may bahay na si Ma'am Mike. So Dr. Maselle, we are ready for your sharing tonight and you feel free to share your screen po.
Oh, you're on na.
Good morning, good evening sa inyo dyan. I'm so happy na I'm able to reconnect with Melba. We have had our experiences sa SBCF sa UP, and I have been busy sa Mississauga and in Toronto. During as much as I can, I volunteer my time giving presentations, giving talks on overcoming the stigma of mental illness, and most recently, COVID-19 and the impact on mental health. It's just incumbent upon us physicians just to disclose conflict of interest. I have done presentations for different pharmaceutical companies who are excellent partners in patient care. But for today's presentation, this is unencumbered and it's voluntary. I will read my testimony and I'd like you to follow with me. I'm tired of washing my hands. My skin is getting red and raw. I remove my mask. I think my hand is contaminated with the virus and I wash again. The mask is hanging from my rear view mirror. My car is running. Am I aerosolizing the virus? I think I'm developing a sore throat. I take my temperature as soon as I get home, 35.6. The hospital starts sounding like the military. We physicians can get redeployed. My co-graduates from the UP College of Medicine post every so often some of our mentors and colleagues who have tested positive or are intubated, which carries a dismal outcome, or have succumbed. We physicians are supposed to be invincible and to treat, but we have suddenly felt so vulnerable and impatiently waiting to be the next victim. My patients report all sorts of nightmares, crowds converging on them, blowing the virus to their faces. We're going to give you COVID-19. As their psychiatrist, it reassures me more than it reassures them that my own dreams are not unusual. But I cannot use my patients as my doctors to validate my own fears as not abnormal, because in the treatment setting, you do not switch roles. Psychiatric disorders have already pushed a second wave of medical morbidities. All sorts of illnesses like obsessive compulsive disorder, anxiety disorders, major depressive disorder, and so on, delusional disorders, post traumatic stress disorder, are on the rise. Those with such histories should adhere to their medications to remain protected against devastating recrudescences. Those who are negative for past psychiatric histories and those who do not have such genetic diathesis should somehow feel reassured that a lot of our fears and anxieties are not abnormal as we day to day face this inevitable pandemic where there does not seem to be any glimmer of hope or end in sight. It's taking so long now. I tell my patients who I sense have a trust in bigger powers that their faith will keep them well. They feel good when they hear that from their doctor. I do not understand a just and merciful God allowing morbid COVID to wreak havoc on his creation. But my finite mind is not meant to understand his infinite wisdom. The old adage, I do not know what the future holds, but I know who holds my future. COVID-19, just to briefly recap, the spectrum ranges from being asymptomatic, which is up to 40%, to a fatal course. And among those who are symptomatic, most are mild, and about 15% to 20% are severe. Incubation periods anywhere from 4 to 5 days average, but for public health purposes, we assume up to 14 days. And symptoms are very nonspecific: cough, myalgias, headaches, diarrhea, sore throat, smell or taste abnormalities. There are no specific clinical features that can yet reliably distinguish COVID-19 from other viral respiratory infections. You look at laboratory parameters, there's lymphopenia or a drop in the white cell count, there's elevated D dimer and elevated inflammatory markers, which we'll review later. Mortality is high, and there are different mechanisms of exit, like acute respiratory distress syndrome can manifest shortly after the onset of difficulty of breathing. There are thromboembolic events that can lead to stroke and heart attack. You can have congestive heart failure, you can have renal failure, and other inflammatory complications. You and I know of the various tests. You've had the nasopharyngeal swab, which is referred to as the reverse transcription PCR, polymerase chain reaction. There's the rapid PCR tests and antigen testing. Now, not only are we suffering from the stigma of mental illness, but even the stigma of having COVID-19. And social stigma in the context of health is the negative association between a group of people. It initially was with the Chinese, and then here in Mississauga, it's with the East Indian population, who share certain characteristics in COVID-19. During this pandemic, people are labeled, stereotyped, and discriminated against. We have a patient who is Vietnamese, and he suffers from schizophrenia, and most recently he tested positive for COVID. And his landlord knew about him testing positive, and he was evicted from his apartment. Sad state. Now, no one is immune from COVID-19. We look at some of the epidemiology, even hospital-based doctors and nurses. In China, this is early in the course of the illness, from January to February, March 2020, population of about 1,200 About 12% suffered from moderate to severe anxiety, 15% from moderate to severe depression, 8% from insomnia, 35% from traumatic distress. About 25% to 33% had mild symptoms of anxiety and depression. Now, what about patients with COVID-19 themselves? Now, there have been about 12 studies in the acute phase, more than 900 patients, and we can see how COVID-19 affects the central nervous system. Patients can present with confusion and impaired consciousness. In one study of 144 patients, 35% have had anxiety, 28% presented with depressive symptoms, and again, one study here, 41% presented with a delirium-like picture, confusion and hallucinations and disorientation. 26% presented psychotic, and again, dementia-like picture or other mood disorders. So we can see not only does it affect the respiratory system, but it can affect the central nervous system, presenting with all sorts of neurological and psychiatric symptoms. Now, what about patients with pre-existing psychiatric illnesses, those with depression, those with bipolar illness, those with schizophrenia, before even COVID came? Now, it's known that just the presence of COVID, you know, the distancing and the social restrictions have had adverse psychological effects on patients who suffer from existing psychiatric illnesses. It may exacerbate pre-existing psychiatric diseases. Patients with schizophrenia may experience worsening of their psychotic symptoms. They may incorporate the virus into their delusions, and they can have cognitive deficits. They get disorganized. More so, they may even develop new comorbid psychiatric symptoms. So the patients actually with schizophrenia might suffer from comorbid depression. They can suffer from panic attacks or even obsessive compulsive disorders. General population, this is a group of Chinese students, grades 2 to 6, quarantined for about 14 days. About 20% suffered from anxiety and depression. 65% were worried about getting infected. Now, how does COVID-19 trigger psychiatric symptoms or psychiatric illness? Now, we think about biological and psychosocial factors. So the fear of becoming ill, and we hear about people losing their jobs. We hear about our friends getting sick, getting intubated. We hear about the high mortality rate. It becomes very discouraging. And the complete change in the world. Suddenly we cannot travel anymore. Suddenly we're restricted. We feel like we don't have our freedom. And then there's, when people are locked down, there's potential for increased domestic violence and marital discord. And then people have lost their jobs. And all these psychosocial factors can trigger psychiatric symptoms in those who are vulnerable. Now, I was alluding to COVID-19. What about the behavior of the virus itself? It's known that COVID-19 can directly affect the central nervous system, causing symptoms like dizziness and headaches and so on and so on. Now, let me show you this diagram here. This is a resting microglia. Now, microglial cells are the support cells in the central nervous system. They're supposed to be protective cells. They're supposed to be, they're the macrophages. They engulf actually any virus or any bacteria that attacks the central nervous system. In the presence of inflammation or infection, they get activated. And when they get activated, they release these pro-inflammatory cytokines. Now, the presence of pro-inflammatory cytokines itself in the course of COVID makes the condition or makes the disease process more fatal. So that some of the medications used to treat COVID actually are pro-inflammatory cytokine inhibitors. And there's an elevation of interleukin-6. Again, once this is elevated, this just suggests a more fatal outcome. And the presence of these inflammatory cytokines will trigger oxidative stress, And oxidative stress imperils the neurons and can cause positive symptoms like psychosis, like depression, or negative symptoms like poverty of affect or lack of a drive. Cognitive symptoms, they get confused and they have difficulties with concentration and memory, or even increasing cortisol levels can trigger depressive symptoms and anxiety symptoms. So all these cascade of changes actually following the presence of anything, inflammation or infection in the central nervous system that are coming from unactivated microglia triggers this cascade leading to psychiatric symptoms. Now, what about the course of the illness? Patients with COVID-19, 1 year after ICU, they suffer from recalcitrant anxiety, depression, and PTSD. Patients with pre-existing psychiatric illnesses, again, they can show, as I said, deterioration in symptoms, anxiety, depression, insomnia, or even coping poorly. Some can cope well. Patients with eating disorders like bulimia nervosa, they can show increased restriction in food intake, or so there's worsening of the condition, or increased exercising, again, which is a sign of a worsening condition. Patients with schizophrenia, they're likely to suffer from COVID themselves. So they have schizophrenia and then they can have COVID. Because of homelessness, social circumstances, it's difficult for them to follow actually the COVID protocols. It's difficult for them to buy masks and things that are needed to protect yourself. Now, it's not uncommon. We talk about the stages of grief when we lose a loved one, that we ourselves or many people go through the stages of denial, anger, bargaining, depression, and acceptance. Denial is life goes on as though nothing is happening. So we just carry on with our day to day, and sometimes we are not cognizant of the risks, and sometimes we just have the attitude like, let's just have more activities for the young people, youth camp, and so on and so on, and leaders in churches, when some of their uh, uh, church members actually get sick or have psychiatric symptoms, leaders feel unsure about how to handle them, and they just carry on with their activities, neglecting or ignoring the mental health issues of their brothers and sisters. What about anger? We can be angry at friends and family whom we cannot visit. We blame and shame the church as not a safe place to go for people who are suffering psychiatric symptoms. Bargaining, is there anything else we can do to fight this virus? And there's the attitude like, mag-pray ka pa, kulang ka lang ng faith. It's this kind of bargaining attitude. And some businesses resisting restrictions, claiming that they're essential services. Depression. Healthcare workers are tired. It's the same routine, donning and doffing PPE every day, and just one slight mistake and you're dead. The virus attacks. And then acceptance, exploring options. Where do we go from here? This is our new normal. We are reminded of the importance of our relationships with family and friends. But then, just as we are in the acceptance phase, the whole process begins again. We go to denial, anger, bargaining. And when people are in different phases, then there can very easily be conflict, especially if husband and wives are both in the anger phase. So general approach, again, step care, which is efficacious and cost-effective. Monitoring for mental health problems. Surveilling for domestic violence in the home and child abuse. For mild symptoms, self-help materials, or speak with your nurses, social workers, psychologists, psychotherapy, counseling. And patients complain, or we complain about being bombarded with this unrelenting news about the pandemic. And we tell our patients, we tell friends, limit intake of print and broadcast news. When patients start suffering moderate to severe symptoms, consider seeing your family physician and getting referred to a psychiatrist for proper treatment. Now, this is a rating scale that I use for some of our patients, and just for us to have a flavor of what mental health issues are, I ask them to rate their symptoms from 0 to 10, and 10 is bad and 0 is good. And I ask them for the average of their symptoms over the past 2 weeks, because we know that when patients or when individuals are just depressed for today or just for one day and then tomorrow they're fine, it might not necessarily be psychiatric illness. It might not really necessarily be a clinical depression. But if they are sad, they're feeling low, they're crying and almost every day, they're incapacitated, they're losing weight, and they're just not thinking properly, their memory is affected, and things here like the concentration, motivation, all these things are gone, then very likely you might be suffering from an illness. And I tell my patients and I tell people and I stress the fact that it's very important for us to receive treatment because psychiatric illness is neurotoxic. It kills brain cells. You cannot just wait for it to go away. It's just like any other disorder. Once you have congestive heart failure, you cannot just tell your patients, get out of bed and exercise. You have to do something about it. If mental illness is not treated, then of course you just keep on losing brain cells, and there is heightened risk of all-cause mortality like diabetes type 2, ischemic heart disease, stroke, cancer, and Alzheimer's. We know that patients with bipolar disorder, the most common mechanisms of exit are suicide and cardiovascular disease, so they have to be treated. Patients with attention deficit hyperactivity disorder, if left untreated, they can be involved in more accidents, car crashes, or they can get expelled or drop out of school. They get into substance use and abuse. Occupationally, there's absenteeism, or even their productivity is dropped, and there's increased incidence of divorce and separation. Patients with psychotic disorders or even schizophrenia, we know that especially if they're hearing voices and the voices will have a command quality, and it can be risky because the voices might be ordering the patient who is psychotic to kill your loved one or making you believe that your loved one is an imposter. So it's very important. And I remember years ago when I was young and I was on call in the emergency room, and I saw a group of Filipinos, and I asked who was the patient, and this young man actually already was diagnosed to be schizophrenic in the Philippines, and everybody actually who were with him were the elders in his church. So I asked him, well, what's been happening? And lo and behold, the patient had been suffering already from psychotic symptoms actually for weeks and months. And then I asked them, so why are you bringing him only here? They were trying to exorcise this sick schizophrenic of his psychotic symptoms, and when he started becoming violent, they just brought him to the hospital emergency. And I told them to pray for me that I will choose that God will guide me to choose actually the best medication for him, and it's good that he was compliant and he responded well. Now, I'm just looking at my time. Physicians are not immune to mental illness. We can see here that in this study, of those physicians actually in this study who were suffering from psychiatric illness, 85% were given a diagnosis of schizophrenia. In this other study by Jones, those physician patients who had psychiatric symptoms, 2/3 were given a diagnosis of depression. Now, even among pastors, and we have had patients in our offices actually who are pastors or even pastors' wives. 75% report severe stress causing anguish, worry, bewilderment, anger, depression, and fear. Why do people not seek treatment? Now, I did a survey way back in 2009, only a small group of 44 respondents. ask questions. Do you know Filipino Canadians or Filipinos who suffer from paranoid beliefs and so on and so on? Do they go for help? Yes. And what do you think could be possible reasons why they do not go for help? Stigma. Stigma. So, I mean, I will stop there. I'll stop there. We can have discussions about overcoming stigma. We can have discussions about whatever questions you have, or some of the psychiatric issues that I raised in this past few minutes. I'm giving the floor to you guys.
Yeah.
Yes. Maraming salamat, Dr. Maselle. What a rich presentation, ano, Kuya Jail?
Yes, I was thinking that this is the first time that we've had a psychiatrist. For the most part, we've been having historians, sociologists, psychologists. So the lecture today felt like, yeah, okay, this is really psychiatry, and there's a lot of things to unpack. No, siguro, yeah. We want to encourage our audience. Many of you, I know, we see are based in Canada. Marie will be greeting you in a bit. We encourage you, though, to please put in your questions there. We want to be as interactive as we can be. And we will bring them up to Dr. Maselle in the course of our open forum. So, Dr. Maselle, siguro the first question that we would like to pose to you is this. Is COVID-19 unprecedented? You've had a long career, you've had a long experience as a psychiatrist. Is this unprecedented, or does this remind you of a previous experience back in time? And or if not, how different might this be in terms of what's happening and in terms of how doctors like yourself are responding?
Well,
Simulan po natin doon.
okay, yeah, we've had experience before with SARS and H1N1, and I mean, I have a slide actually sort of showing the mortality among Canadians and how long they lasted for. And so initially, I mean, Fridays, Mike and I, we used to go to our dances at the 30th club, and even our friends, during the start of pandemic, it was the phase of denial. It was almost like, oh, we've been through this before. We've been through a viral infection before, and we hear about people getting intubated. We hear about people dying, but we did not sort of appreciate that it was just uncovering. It was only the tip of the iceberg, and then it wasn't going away. And then we heard that it was happening elsewhere, but the attitude in Canada was, it's not coming to Canada. That was a phase of denial. And then it started getting into the hospital system, and then we started closing down services. Cancer surgeries were canceled, and other patients actually with other medical morbidities actually suffered because suddenly the priority was shifting to attend to COVID patients. And then it was just getting to be too long and too long. So the trajectory, the magnitude of this really is unprecedented. Whereas initially it was just a phase of denial, like it will just go away.
Yeah.
But then, we had to do something about it.
Yeah, you can say the same thing about the Philippines, Dr. Maselle. Around January or February last year, even public officials were in denial. And to a certain extent, I counted on those words, hoping that, yeah, sana totoo yung sinabi nila na ano lang to, hindi to masyadong mag-i-impact sa atin. Like SARS. SARS did not really hit the Philippines. Back in 2003, I was still an undergraduate at that time. Tinamaan Singapore, tinamaan Hong Kong. But the Philippines, we were safe, Pero this time, tapos kahit actually talking about denial, Dr. Maselle, kahit po when university, so I teach sa Ateneo, when our campus was shut down, we were believing that, oh yeah, maybe after 2 weeks or 3 weeks we'll be back. So iniwan ko lang yung mga gamit ko doon without realizing that it would be extended and extended. So I had to get all my books, which are now here. Otherwise, I wouldn't be able to work. So the denial is there. Now, let me latch on to that. Is that normal? Is it normal to deny? You mentioned that a little bit kanina sa presentation nyo. Is that normal? Is it healthy? And how should churches respond to that?
Psychiatric symptoms or even the phases of grief is a very normal process. So we don't pathologize when people present with denial. It's just understanding that this is our way of coping, and even getting angry, just like in the face of grief. As long as it doesn't become a pathological anger to the extent that people are getting hurt. It's allowing the person to go through that phase and watching. So it's almost like say if any patient actually had an infection and the person will have a rise in temperature or even a cough. It doesn't mean that you panic and you suppress the cough, because the cough is a mechanism to expel the bug. See, and fever actually is a mechanism to kill the bug inside the body. So just allowing people, not even patients, people to go through a variety of emotions actually should be encouraged and let them go through it.
Ayun. I think that's one of the things that we picked up talaga, Dr. Maselle, from your presentation, no? How you walked us through yung stages and how different people respond to it. Yung mag-pray ka lang or babalik din to sa normal, wag kayong matakot, babalik din to. Pero actually, sabi ko nga, nagbibiroan kami, kita-kita tayo sa Pasko ha. That was our joke. March of 2020. And December 2020 na, Pasko na, alam niyo naman po kung gaano kalaki yan dito sa ating bansa na selebrasyon, pero hindi pa rin kami nagkakakita-kita. Dr. Maselle, I just want to emphasize kung gaano ka-powerful yung inyong presentation and how you started sharing your story, that you're tired of washing your hands na din, and that you also have this fear when you go to your practice. I think a lot of us were really able to relate. One of my things that latched onto me as you presented, and it gave me a sense of urgency, is that psychiatric illness is not like any other illness sa katawan, because what it does is it kills our brain cells, hindi ba? So actually I had to write that down noon. So this gives me that sense of urgency, and also at the same time iniisip ko sa ating kultura, if I may say, talagang hindi pa siya ganun na haharap. At talagang sabi nga nila masasayahin ng mga Pilipino, and we are grateful for that. Maybe the sun is a factor, hindi ba, Kuya Jail? But I think we need to really face how important this issue is. Bago ko po isabihin yung tanong ko, na kailangan ko lang batiin tong mga viewers natin. And may mga messages sa inyo, Dr. Maselle. Babalikan ko po yung tanong ko. Pero sabi lang po nila, Ma'am Dr. Sally Villos, sila Pastor Noe Villos. Hi Maselle, hi classmate. And sabi po sabi po ni sabi po ni Pastor Noe, watching from Teachers Village. Hello, Sir Alex from Negros, and Al Calixto from Negros, and Miss Jean Baguio Angeles. Hi, Uncle Maselle daw po, and Tita Louie. And sabi din ni Milagros Alba, great to see you, our DG leader sa SBCF. So, a lot of people are wanting to say hi po sa inyo. And let me just go back now to my question. Hello sa mga viewers, please keep your comments coming. Sabi ni Veronica Esther Mendoza, napakaganda po ito, no? So, bukod dun sa tanong ko sa kultura natin na parang binabaon natin yung mga ganitong issue. Sabi ni Veronica Esther Mendoza, in the absence of enough numbers of psychiatrists and psychologists in any country, what do you suggest, Dr. Maselle, that could be done to help the people with mental health issues. And that's a thing in the Philippines. We don't have enough counselors, psychologists, and psychiatrists. I think our ratio is really beyond the acceptable level. What can you say about this, Dr. Maselle? Ano yung pwede nating gawin?
It's very important na I think looking back nung estudyante pa kami ni Sally. Hi Sally, Dr. Dr. Sally Nicdao Villas. We were still in UP noon. And the medications we had at that time, dalawa lang Haldol tsaka chlorpromazine. We look at the evolution of psychiatry as a specialty, and there's a renaissance of all sorts of medications, and it has become a challenge because now I can look back and say these patients actually whom we thought were suffering just like this actually are suffering now from this condition, and we are better able to treat them. So that's just very basic, yung diagnosing a condition. So how much more if we look at the early stage ng clinical presentation and whatever that person is going through. The person might be presenting with symptoms, and then we might still be thinking normal lang sa kanya, not knowing that the person could in fact have become more productive if the symptoms were diagnosed properly and treated. For example, may isang Filipina who was attending McMaster University, and takang-taka siya kasi all through her life, high school and early university, she was a bright student, a high achiever. But then she started having difficulties, and she started researching her symptoms. Tapos naisip niya na, meron kaya akong ADHD, attention deficit disorder. She was on academic probation. She was about to be expelled from McMaster University. So she went to her family physician. Ang maganda naman dito sa Canada, kasi you can always go to your family physician, services are paid for, and then they screen, and then they can refer to you to a psychiatrist. So the family physician thought that she was just there kasi she wanted stimulants, and this can be addicting. But so she went to another family physician, and eventually she was referred to me. And I thought that she had ADHD, attention deficit disorder. Treated her with a stimulant, which got her out of academic probation. She did very well, and she was able to enter law school. She graduated on the dean's list and was able to enter law school. And then she comes back and is very grateful because you're able to diagnose actually a condition that otherwise would just have festered and contributed to incapacity. So marami sa atin na we would just think, oh, tamad yan. Kaya yung mga individuals who might be aggressive or who might be parang insensitive, plus may mga mood swings, parang they can be explosive. Kapag ganon, if you remember the rating scale that I used earlier, I ask about anger, I ask about irritability. And if these patients score very high, then I ask about mood swings. They ask, Doc, what do you mean by mood swings? Well, you can be extremely happy, you can be extremely depressed, you can be irritable, and your moods fluctuate up and down like a yo-yo. You might be missing a bipolar illness. Put them on a mood stabilizer, they change and they function better. So it's a variety of experiences that that not only from the Philippines, even in Canada. And we think about cultural differences, but mental illness remains the same. Okay.
Yeah.
So, yes. Go ahead. Yeah.
Doc Maselle, that really that begs the question about health-seeking behaviors. Kasi dito sa Philippines, public health experts know that the health-seeking behavior of Filipinos is pretty low. Which is very consistent with the question. I think this is what Jane is trying to ask. Si Jane Pagio Angeles, sabi niya, given the silo on depression, there's that tendency of not sharing what one really feels, di ba? Hindi ka hahanap ng tulong. How can I encourage others to be more open and not just think that what they are feeling is, quote-unquote, lilipas din ito? how would you encourage Jane, somebody like, or even me, helping other people as a minister?
Correct.
It's a challenge.
It
It is a
is.
challenge. It is a challenge because I mean, even those patients who already went to a family physician, okay, or somebody actually who goes for counseling, and there are many astute counselors who will think and who will say, well, this person is not just suffering from issues, but they would think that there might be something else psychiatric happening, which means baka bukod sa problema niya, this person is really suffering from some kind of an illness. So it's referred to the family physician, and the family physician confirms, for example, na may depression ang pasyente, and gets referred to a psychiatrist. And then I get to see the patient and confirms again the diagnosis that in fact very likely may depression. And then you discuss treatment. Okay, you discuss treatment, and then the stigma of medications, and people will think, oh, hindi ko talaga kailangan yan. Ano, wala naman akong sira sa tuktok, ano? So they will think they don't need it. And just the educating about what their fears are, asking them, kung, what are the resistances taking the medication like this, and you educate them about it, and then I tell them, look, these are the risks involved, and I don't stop there. I tell them, if you so decide, just call the office, you can, and then we can see again, we can review. Now, having that discussion, so educating them about symptoms, educating them about a possible illness that's potentially treatable, and that there are options, their symptoms actually drive them back, and they say, doctor, you told me about this and that and this and that. I'm not scared of the side effects anymore because it's really getting to me. So kahit na awareness nila na these are the potential risks taking these medications, the fact that they're suffering from symptoms is more than sufficient to drive them to go for help. Now, kahit naman mga Filipinos who are our patients, it's the same thing. But yung sinasabi ni Jane, people in the silos, and people are cocooned by their family or even by the church na normal lang yan, that will go away. Well, I mean, miracles happen even in medicine, okay? So even those patients whom we thought wala na kaming mga gawa, but they still get better. Miracles happen. So those patients probably who don't even undergo treatment, they might get better. There's always a spontaneous remission, or again, miracles can happen. But short of those things, I think that we have to be as family cognizant that this is not my son, this is not my brother. There's something wrong with him. Okay, and more so, especially if the patient is on treatment. Ang mahirap yung kapag sasabihin ng family, bakit mo pa tinitake yan? Hindi mo na kailangan yan. Kailangan magpalakas ka lang. And once you stop treatment, I tell my patients, kapag may diabetes ka, you think that your blood sugar is fine, you stop it, your blood sugar goes up. You have high blood pressure, and then you check your blood pressure, you're put on medication, your blood pressure is fine, you think hindi mo na kailangan, you stop it, your blood pressure shoots up. Same thing with mental illness. Patients will think, oh, nakalimutan ko yung gamot ko sa Sabado, wala naman nangyari sa akin, maybe I don't need it anymore. I tell patients, mental illness will show itself, recurrence will show itself within the next 6 months. So when they come back sick again 6 months later, they would have forgotten already that the reason why the illness comes back was because they stopped their medication. So it's important as a family to support the treatment and encourage the patient to remain in treatment.
Thank you, Dr. Maselle. Basahin ko lang po muna ito bago ako magbasa din ng ibang comments. Sabi po ni Miss Eden Cruz Lim, nice to see the both of you, Dr. Maselle, and hello, classmate Mike. And stay safe daw po sa inyo. Dr. Maselle, we have this comment from Sir Bernard Supetran. Sabi niya, stay home, save lives mantra doesn't work here, particularly prolonged home confinement took its toll on people's mental health, which is largely unmeasured. Travel and outdoor activities are indispensable if we are to remain sane and not just safe. It's something that the Manila Bay Dolomite, if you're familiar about it, if you've seen it in the news, sabi nila, may improve daw ang mental health pag may white beach sa Manila, white sand sa Manila Bay, pero hindi naman na-achieve so far. Ang tanong po na gusto kong basahin kasunod nitong comment na ito ni Sir Bernard ay yung tanong ni Tim Ngo. So we were talking about diagnosing, pero sabi ni Tim Ngo, what about the poor? Sabi niya, how do we introduce mental health to them? It seems like the acting out always comes first before understanding severity or the severity. The comprehension or introspection is so foreign to them, it makes it so hard to move to the direction of healthier coping patterns for them. Dr. Maselle, your comments on this question po.
Yeah, it's I was alluding to the survey that I did way back in 2009, and it looked at all these factors, and I mean there are so many issues, so many issues, but as I was saying earlier, mental illness or depression or schizophrenia or bipolar illness. You can have variations in clinical presentations, but the illness is the same. So kahit mahirap ka, o kaya kahit mayaman ka, you might have luxuries, but it doesn't protect you. It doesn't protect you from the illness. So kahit may white beach ka doon and so on, it might make you feel good, but if the illness just has to run its course, it just runs its course. Wherever you are, kahit mayaman ka, kahit mahirap ka. And the sad thing in compromised or in marginalized sectors or social groups is maybe, I'm saying maybe, because of lack of services or convenience ng whoever are providing services, it's just easy to lump them together as walang pag-asa yan, o kaya talagang ganyan lang ang buhay niyan, and so on and so on. And but if there are ways by which these people can be referred for proper assessment, proper diagnosis, I'm surprised, Marina, and this is still happening in the Philippines. When we were medical students, I mean, Sally will remember this. Nagpupunta kami sa San Andres Bukid and so on and so on, and kahit na nasa Bai kami sa Laguna, that's how I met my wife Mike. You get to know yung grassroots level ng not only presentation ng mga common medical illnesses but even psychiatric disturbances. So I think it's I mean kahit dito na ang hirap-hirap mag-refer sa psychiatrist, sasabihin ng mga kasama na yung mga physicians na you refer to a psychiatrist, it takes about 6 months to a year for psychiatrists to be able to see the patients. It doesn't have to be an excuse. Kahit na you can still see, and in hospitals, you can see like a pyramidal structure na ang counseling is provided frontline, and then you have general physicians looking after general health, and even prescribing of medications. And then the more challenging cases in terms of diagnosis or patients who are not responding are consulted, are referred for consultation with the psychiatrist just to see it's not working, what do we do now, and what medication choices do we have. So it can be very pyramidal. So it doesn't have to be na maraming psychiatrists or maraming psychologists or maraming mga mental health nurses, but looking at how to provide the services, especially sa mga needy, especially sa mga lower income groups.
Yes. Thank you, Dr. Maselle. Sabi tuloy ni Willie Villarama, Boyson Villarama, sabi niya, ano ba talagang priority? Gutom, ulam, face mask, face shield, at yung mga LGU ay hindi naman tumutulong at inaaresto pa sila. So I think it goes in line with that. If there's a will to help, there's always be a way to do it. Speaking of will to help, Kuya Jail, no, what the church does here in the Philippines ay nagkakaroon ng psychological first aid training po, no? And I know that DSWD also had their wave of seminar, especially during June and July, nung kataasan na ng pandemic na nagkaroon ng mga psychological first aid seminar. At yung mga umattend doon sa mga seminars na yun ay mga churches. So tanong ni Dr. Sally Villas to you, Dr. Maselle, is what do you think of churches training first line or frontline counselors just to listen and engage with people who may just need someone to talk to? What do you think of this first aid solution na nangyayari po ngayon on the ground?
I think that's an excellent idea. I think it's an excellent idea. I mean, even when I was working in the hospital and may mga patients na nire-refer for a psychiatric consultation. And, you know, parang sa akin, kung minsan maiinis ako, isipin ko, oh, this is basic na ang kailangan lang ng pasyente. It doesn't really need a psychiatrist. The person needs someone na may makakausap. So it can be bedside nurse, kaya a social worker dealing with family issues and so on and so on. I think we always have to distinguish problems, psychosocial problems from mental illness, from psychiatric illness. And if psychiatrists are made to deal with psychosocial issues or even problems ng pang-araw-araw na buhay, then services are not allocated properly. So I think yung idea ni Dr. Diaz, ni Sally, it has to be done, you know, and hindi lang sa mga churches, kundi sa mga different groups, kahit sa mga offices, kahit sa mga businesses, na there would be some employee assistants, counselors, and so on and so on to help employees deal with stresses. Kasi hindi naman necessarily na may mental illness na yung employee niyan, but just needs assistance to navigate through yung mga stresses sa buhay niya, okay, conflicts with their bosses or other issues, you know, counseling and so on and so on. I think it's an excellent idea.
Thank you, Dr. Maselle. Kuya Jay,
Yeah,
I have a question to ask.
that's right. We need to wind down now, no, Dr. Maselle, and we have so many other questions. Maybe we'll have another episode eventually. Pero ito, nabanggit niyo nito kanina sa presentation niyo, Dr. Maselle, and I'd like you to expound on this a little bit more. Many churches kasi theologize depression, theologize mental illnesses as a spiritual problem. And therefore, the solution is to pray it away. Help us think through that. How would you respond to that when you hear pastors? I'm not asking you to make enemies, not today. I'm just asking you to help us think through this. Baka naman kailangan ng konting reflexivity on the part of ministers. Talking about church response kasi. No?
Yeah, it's difficult. It's difficult, and it was just so interesting. I remember I was invited to talk about overcoming the stigma of mental illness, and this was a group of Baptist pastors, and I started feeling like my presentation was unwelcome, and then they started talking about medical illnesses or psychiatric illnesses as originating from the fall of man and so on and so on, and unless people ask for forgiveness for their sins and so on, and things will be fine. I mean, I'm not against that. It's excellent. It's a very Christian thing to do. It's a very good orientation. Pero yan ang sinasabi ko. That is something else. That is your faith. That is Christianity. But it's not mental illness. It is not psychiatry, because we're dealing with psychiatry as a specialty. We're dealing with people actually who are suffering from an illness. All right. So I think it's sad kasi if you keep, just like yung example ko kanina, if you keep a schizophrenic actually who is suffering from delusions, and then you diagnose that this patient actually is possessed by the demon, and ang treatment is exorcism, nakakaawa naman yung pasyente. Kasi it's a wrong diagnosis. But But you might look at it in the context of another group, and people will think it's like this. This is what's happening here. Kung siya, unholy siya, possessed siya, and so on and so on. And he has to ask forgiveness for his sins, and that's another story. I won't even get into that. And I just feel bad. And we have to think, are we keeping someone actually who is suffering from bona fide psychiatric illness? Are we keeping them cocooned because of our churches, because of our services, and we're doing the wrong treatment and not diagnosing properly? So parang there are so many things in medicine, and we always have to think about differential diagnosis. Am I barking up the wrong tree? Am I treating what I'm supposed to be treating here? So, it's very wholesome sa akin if I know that my patients have a church to go to, na may mga supportive na mga community, or even a very supportive family, and so on. That's why I tell my patients, sometimes kapag, especially if you're a physician, ayaw mong ilabas you don't want to reveal yung mga biases mo. But there are times when especially those people na alam mo na as a physician wala ka na mga gawa. And then you ask kung they still believe in prayer, kung may faith sila, whether they're Christian, whether they're Muslim, whether they're Buddhist, and so I tell them, you know what, your faith will keep you well. And it's very reassuring for them. It gives them a different kind of a therapeutic healing kahit na hindi gumagaling ang kanilang mental illness. So there's a difference there.
Yeah, research shows that faith is quite important. Yeah, as a mechanism, right, to deal with this. Thanks for that, Dr. Maselle. I cannot resist. Marie and I could not resist. We need to bring this in. Last question. This is from Maurice Parr. Tanong niya, paano po ba i-manage ang response ng kapwa Kristiyano na kulang ka kasi sa faith or kulang ka kasi sa dasal sa issue ng mental health, particularly if you belong to a Christian organization? Might I just add, Dr. Maselle, this is quite a recurring issue every time that we have an episode related to mental health. How would you help? Okay, kanina pastors, how would you help ordinary Christians kapag na ganyan ang na-receive nilang mga feedback? Kulang ka sa faith, hindi ka nagbabasa ng Bible sa umaga. Ganon.
Alam mo, then maybe that person will have to go through a different channel.
Okay.
So maybe that person might have to go to a different channel. I remember, as you're describing, one of our patients who is a pastor's wife. And one thing nice about as a psychiatrist that I get to know yung mga ins and outs of others who are giant Christians. Okay, but they don't want to show their symptoms. They don't want to show their weaknesses at church because it's not welcome, or they will think, well, spiritual giant ako, I'm not supposed to be feeling like this. But they're suffering. They're not suffering because of lack of faith, but they're suffering because of a medical illness. So, unbeknownst to the church, kahit sa husband niya, sinasabi niya, he's suffering like this. And nobody would listen to her. Mag-pray ka, kulang ka sa prayer. So she went to her family physician, and then she was referred to me. And then she started talking, and I realized that hindi niya alam Christian ako, but I just kept it at that kasi I wanted her to feel free na hindi siya hindi siya mag-judge, and if she will know na Christian ako, baka hindi na siya babalik, and she will think na I'm in cahoots with the church. So she started talking, and proper diagnosis, proper treatment, binigyan ko siya ng gamot. She was feeling much better. She was able to function better. She was able to think better, concentrate better. Maybe her relationships are still the same, but the degree of distress actually was very much lessened for her.
Wow. Dr. Maselle, talagang bitin. I remember emailing you and asking you, let's talk about stigma, pero hindi nga natin nakutkot yung topic na yun dahil ang dami na nating napag-usapan. And I know that our viewers are so engaged until now. We have retained them. Maraming salamat sa inyo for joining us tonight, mga kasama namin sa ISIP-ISAK. Siguro po, magbabasa lang ako ng mga komento. Yung iba tanong, pero komento that I think gusto kong pag-isipan nating lahat kahit na umalis na tayo dito sa ating live stream tonight. Ang sabi ni Jonic Banal, I really like this comment. I told him it's a good point. Sabi niya, isn't it about time that sick leave for mental wellness should be normalized? At sabi pa, katulad din yan, or karugtong yan, sinabi ni Miss Jane Pagyo Angeles, why is it very challenging to get mental health coverage? Ayan. Siguro, Kuya Jail, dumako na tayo sa mga nagets natin. Ang akin lang pong nagre-retain sa akin ngayon is that when we think of COVID and we think of comorbidity, we think of heart, we think of the lungs, yung diabetes, high blood pressure. But I really love the point you made, Dr. Maselle, that when we think of comorbidity, we also have to think of the mental health, no? And especially yung mga psychiatric issues. Kasi minsan natatabunan yan eh. And then also po, ang gusto ko lang din talagang i-drive home ngayon sa ating mga kasamang pastor, because I too am a minister, no? I also serve in our church. Hindi nang hihina yung pananampalataya natin pag tumawag na tayo ng mga health experts. Hindi ibig sabihin nun na ito ay asunto o ito ay attack against our faith or the strength of our belief that we will be healed. I always see doctors, especially psychiatrists too, and of course medical doctors, yung mga sa kalusugan natin, na sila ay biyaya din ng Diyos para magkaroon tayo ng yung pinangako ni Kristo na buong buhay, yung a life that is abundant and full. So wag tayong matakot, di ba no, Dr. Maselle, maghanap ng avenue at meron mga faithful na mga mananampalatayang health experts na willing tumulong sa atin at sa mga kagaya ng mga mini-ministeran ni Tim who are the homeless here in Manila. Kuya Jail, ano ang gets mo ngayong gabing ito?
Sa akin, all the more that we need to push for this consciousness among the people of God. Gaya na nasabi ko kanina, there's this it's a recurring theme every time we have episodes related to mental health, about the trauma that our brothers and sisters experienced in their respective congregations. They were asking for help, but all they got was what they felt was a rejecting, statement, dismissive statement. You're not praying enough, or you're not reading the Bible enough. And if there's one thing that these past episodes have been really trying to pound, and this is it. No, now we need to listen to the wisdom of psychology, of psychiatry, the expertise that we heard from Dr. Maselle. And therefore, this is an encouragement to the people of God na it's a stigma. It remains to be a stigma, even though there's this wider consciousness among young people about ADHD and other mental conditions. May generational gap. I think the older ones tend to be dismissive. Tend to be dismissive. Not all, but many do tend to be dismissive. And so I pray that our churches will become transformative spaces where people who are not able to receive this attention will have some ears to listen to them in the form of our pastors or in the form of even us, ordinary brothers and sisters. We want to give you, Dr. Maselle, the time for your final words before we move to Ate Melba for her biblical reflection. Final words, Dr. Maselle.
I'm so grateful to you guys. Parang I always remember na younger days, kapag lagi sinasabi, always take the chance to evangelize and talk about your faith. I find myself dito sa Greater Toronto area, Mississauga. Whenever I have the opportunity, I always want to talk about mental illness. Kasi talking about it just helps educate people about the existence of mental illness, proper diagnosis, and it can be treated. I remember, and Dr. Sally will remember, we had a professor way back in medical school. His name is Dr. Fox, a great surgeon, and he would tell us, that when your patient presents with acute cholecystitis, you don't operate because everything is inflamed. And even as a great surgeon, he told us doing that, temporizing, is not a sign of defeat, but a sign of good judgment. And I think kahit na sa churches, kahit na with families, having to acknowledge that this patient is not suffering from lack of faith, from lack of prayer, but there's something else that is treatable. It's not a sign of defeat, but a sign of good judgment.
Maraming salamat po, Dr. Maselle. What a powerful episode tonight. Si Ate Melba naman po sa kanyang biblical reflection. Nakamute po kayo.
Thank you, Maselle, for the very in-depth na insight on what's happening sa mga tao who may have mental health symptoms sa panahon na ito. Now, siguro just to surface some things that have resonated with me, yung issue ng stages of grief, it looks like baka tayo as Christians, we may think of this pandemic primarily as a transition period, yung tinatawag ng mga anthropologists as well as mga theologians na liminal space, in other words, this is the in-between time when we are no longer very certain about things, yung mga routine structures natin, mga habits natin, we have had to say goodbye to kasi ibang-iba yung context, So, at the same time, hindi pa tayo nakaka-construct ng new structures, new ways of organizing our life systems, ganyan. So, nandun tayo sa in-between time. We are no longer able to function in the old normal, Pero at the same time, wala pa tayong new normal. And yung space na ito is, sabi nila from anthropological, it's a rite of passage. At ang mahirap pag nasa gitna ka when you're in the middle of it. And yung sinabi nga ni Maselle kanina, it's easy, especially for church people, to deny yung reality ng liminal space, ang ating response dito is either we try and go back, balik tayo ron sa usual natin ng mga online services, ganon. We try to go back to the old wineskins, kumbaga, what it means to be church, ganyan. We try to be prematurely inventing the new normal, instead of waiting in this liminal space. Kaya siguro ang Lord always tells us, wait upon Him. Maraming times of waiting and periods of waiting. Kasi much of our life is really transitions. You have left the old life behind, pero wala ka pa rin sa future. So, you're kept, waiting in suspension dito sa liminal space. And I think that's why ang Bible is full of, sinasabi, wait upon the Lord. We have to learn to wait. Hindi yung we prematurely want to go back to the old, kagaya ng mga Israelites in the wilderness. Dahil mahirap yung life doon sa wilderness, they just kept, when they are face to face, with yung mga challenges of capturing yung land na promised to them. I mean, ang dami nilang mga murmuring, dami nilang complaint sa hardship, tapos they eventually want to go back, instead of possessing the land, after yung report ng 10 spies, you remember. Meron 12 spies, dalawa lang yung nagsabi na we can take this land. Sila hindi. Sabi niya, we seem to ourselves like grasshoppers. So gusto nilang bumalik, Gusto nila yung mga leaks, yung nino-romanticize yung life nila sa Egypt when actually they were slaves in Egypt. They were actually being freed, So it's easy for us to be like that. to romanticize yung the old normal. And then to try and recapture that, no? For the present and the future. But if there's anything that God is saying to us sa pandemic na to, iwanan na natin yun. There are certain arrangements of social reality that we may need to what? Hindi lang sa we do not return but reject, no? And wait upon the Lord in such a way na we are able to hear the true normal. In other words, to reinvent, yung siyatawag na new wineskins, because the new thing that God is doing in this liminal space needs new wineskins. At siguro yun ang dapat hanapin natin. Huwag magbigay kaagad ng prescription, but to try and embrace yung ambiguity. Magkaroon ng denial, no? Kung dahil sinasabi ni Maselle kanina, but to confront, front and center what this space means to us, what this pandemic means to us. And siguro kaya nagkakaroon ng problema sa church. Mahilig tayo wala tayong tolerance for ambiguity. We either say spiritual problem ito, no? At kulang tayo ng discernment. It's very easy to have these spiritualizing reflexes. No? To say na, itong taong ito, not praying enough or not spiritual enough or naros kulang sa discernment when actually probably it's just a medical problem. Sabi nga ni Maselle, no? Yung dysfunction is not because wala silang faith sa Diyos, but simply medical, no? Or I think importante rin na there are certain things na hindi natin talaga mahawakan. There are new things happening dito sa pandemic na ito na kailangan natin ma-discern. Ano sinasabi ng Diyos? What is He saying to us as His people, no? In a period like this? And ako, from where I sit, I am still waiting for God to tell me ano po yung bagong normal. Ano yung new arrangements of social reality that should take place, no? Alam mo, yung sinasabi ni Maselle kanina na yung mga poor, halimbawa, yung mga homeless, many of them actually mukhang mga village idiots. Hindi pa dito sa ating kultura, meron tayong tinatawag na village idiots, no? Baka for all you know, it's because nag-deteriorate na nga lang yung brain cells. Sabi nga that's a good insight for me, medically. Sinabi ni Maselle na maraming homeless na actually, it's because nag-deteriorate na yung brain cells Kaya mukhang sira ulo, ganon. And yung sinasabi ni Tim kanina, baka so many of our homeless, yung mga street dwellers natin, are experiencing itong mga aberrant na behavior. Kasi nga, untreated sila for so long. That's a very good insight from Maselle, no? Kasi wala namang access sa medical services, ganyan, whatsoever. So siguro yung those of us who are people helpers, maganda na i-discern natin na maigi. Is this a medical or a spiritual problem? And yung sinasabi ni suggestion na magkaroon tayo ng mga non-formal na mga helpers, no? Mga people helpers who can be trained to simply listen carefully sa mga tao. That's a very good idea, and I think I hope ang mga churches natin can start doing that, na hindi ko mo kailangan may PhD sa psychology, whatever, no? So that yung sinasabi ni Veronica na i-massify natin yung ating ability as a community to listen to one another. And this, I think, gives me yung punto ng, ang isa siguro na hindi natin pa dapat na pag-iisipan, yung cultural trauma natin. Kasi yung kultura natin, punong-puno ng rituales much of our culture has to do with what we do with the dead. Ang problema lang, ngayon sa COVID, wala kang yung people suddenly, I think part of the reason people cannot overcome yung grief, no, of losing loved ones. Wala kasi sila doon. Sanay tayo as a community na hawak-hawak natin yung kamay ng mga pasyente natin or our loved ones hanggang mamatay. Kaso wala tayo doon we are excluded, no, from that space. Pagkatapos, naalala ko itong aking kaibigan, sabi niya, hindi ko man lang nakita nung namatay yung aking anak, ano. Nakita ko na lang yung list niya na merong na siya ay patay na at iadala sa morgue. And of course, he was given to her in a box, no. Kahit na hindi naman siya na COVID, ito lang heart attack. And she cannot get over yung memory na yun, na she was not there, present. At tapos, walang rituales. Lalo yung mga Katoliko, among us, sanay sa mga padasal, sanay sa mga sari-saring wake, and so on. Walang ganon. There is no community to weep with you. And by the way, I have been thinking about yung sinasabi ni Jesus about weeping with those who weep. Sa tingin ko, yung weeping with those who weep is not just for those who are grieving. It's also for those of us as a community. Kasi pagka we are not able to confront yung grief of death and life, ganyan. Ang mangyayari, denial tayo lahat kasi yung mga burial, yung mga funeral, mga ganyan, mga wake, it's a very good way of stopping yung ating activities. Pag ikaw napupuwersa, punta ka sa kapatid mo o sa iyong kapitbahay o neighbor mo, you start thinking about death, you start thinking about mortality, you start thinking about yung corporate grief natin as a community. Wala na yon, nawawala yon. We are not able to stand in front of our pain as a community. No, put it front and center. At yun, hindi sa na meron kang denial individually, no, doon sa grief mo. Posible rin na meron tayong denial as a community, as a national community. Halimbawa, naiiyak pa ba tayo doon sa mga abuso ng gobyernong ito? Halimbawa, yung nangyari doon sa kay Baby River, sino? Na yung nanay hindi pwede pumunta sa wake. She was, nakalagay ng merong suit at saka merong handcuffs, and you have three battalions of security guards. I mean, mga ganon. Are we moved to grief din sa ganong mga bagay? Yung mga pinapatay basta-basta and ganyan. In other words, yung weeping with those who weep allow us to come face to face with the pain of the national community. Hindi lang yung pain natin individually. And I think ang may fallout siguro yan long term. Na hindi natin kasi nga nakaka-depress masyado. Marami akong mga kaibigan, lalo yung aking generation. Sabi nila, Melbs, wala na tayong magagawa dyan. So they get depressed. They're powerless matatanda na, wala ng energy, hindi na pwede mag-demonstration, hindi naman tayo mag-inon. So I think it's important na we think both of yung dealing with the individual na grief and pain and loss, no? At saka yung mga mental health issues that surfaces. And at the same time, to also think of ourselves as a community. Are we lamenting enough? Are we grieving enough? Are we mourning enough for the things that we see around us? No? Siguro yun po ang tanong natin. Bukod sa discernment, tolerance for ambiguity, and yung empathetic na mourning over our communal grief, baka kailangan nating pag-isipan ng maigi yun. And face yung both yung ating psychological and also cultural na trauma together as people of God. So, siguro yun po ang ating ngayon, pag-isipan natin ng maigi. May mga katanungan tayo. And hopefully, we will have, together with si Dr. Maselle, we can have a webinar na medyo we can talk about this more in-depth siguro. As parang ISIP-ISAK na webinar. Dahil may mga issues tayo dito talaga na kailangan ng more in-depth na analysis. But I would like to thank si Maselle, no, for giving us some of the mga psychiatric na insights na kailangan natin so that we can move forward. So, salamat po sa ating lahat.
Yes, Ate Melba, I just want to tell our viewers na manood po kayo next week kasi ito pa rin yung pag-uusapan natin. Pag-uusapan pa rin natin ang pandemic and mental health. We will have Miss Aleli from UP Los Baños and she will tell us naman the scene on how it looks like sa mga kabataan natin, sa ating mga college students. Kuya Jail, I also want to hear you ha. Or that's gonna be next episode. Naku, nag-advance yung utak ko.
Next episode yun.
Oo,
Next week.
Next week pala, mabigat pala yung ano natin, guest natin. Kuya Jay, sino bang guest natin next week?
Next week.
Secretary
Liling Briones. And she'll tell us on the scene no, ng education ngayon sa mga elementary and high school. And then we will have Miss Aleli to follow up on mental health and the pandemic. Excited na ako. This has been a very good episode, right? Maraming salamat po, Dr. Maselle. And next week, it's also something to look forward to with Secretary Briones.
Lovely. Maraming salamat po and God bless you. Dr. Maselle, salamat po. Ma'am Mike, salamat.